if the MRN is negative for entrapment, do you still recommend surgery? So MRN stands for magnetic resonance neurography, which is a type of MRI which is done specifically for the nerves. And one of the problems of doing an MRI or MRN for pudendal nerve, that pudendal nerve is small. And even with the highest resolution MRIs or MRNs, the ones that are called 3 Tesla MRIs, which is the strength of the magnet in the MRI, the pudendal nerve is smaller than the resolution of that MRI. So you do not really see the actual pudendal nerve. You see the surrounding structures, you see the veins and the arteries and the muscles and the ligaments, but you actually do not see the nerve. So it is very difficult to determine if the pudendal nerve is actually entrapped. If there is a lot of scar tissue, if there is a tumor, if there is a mass pressing on the pudendal nerve, then you are going to see it. However, if there is little scar tissue, then you are not going to see it on the MRN, even those best MRNs, the best quality MRNs. So I personally do not use MRN to diagnose pudendal nerve entrapment. It is still the test that is valuable, because if the MRN is positive, meaning you see something abnormal, then that is a positive test, and that may be a reason to do the surgery. However, if the MRN is negative, it does not mean anything. So here at this point we can probably discuss, so how do you actually diagnose pudendal nerve entrapment? So we have already talked about the fact that pudendal neuralgia is a symptom, it is not a condition. Pudendal neuralgia simply means pain in the area of the pudendal nerve. Pudendal nerve entrapment is the condition where the pudendal nerve is scarred in the scar tissue. And that's the one that will require surgery. You cannot remove the scar tissue in any other way other than doing the surgery. So how do you know who needs surgery? So years ago, my mentor, Professor Roger Robert, and his team came up with something that's called Nantes criteria. So Nantes criteria is the criteria which is named after the city of Nantes, France, where Professor Robert practiced, and this was a very long and criteria that told us not really who has an entrapment of the nerve, but really it was validated to tell us who are the patients that will benefit from the surgical decompression of the nerve. However, there's so many different points in this criteria, it is difficult to remember, and it is a lot of those is something that I disagree with. Mostly because our knowledge on pudendal nerve entrapment has advanced. There's a whole new group of patients, women that have been injured by pelvic mesh that don't really fit some of those criteria. And therefore, I personally do not use Nantes criteria to diagnose pudendal nerve entrapment. It was actually never meant to diagnose pudendal nerve entrapment. Like I said, it was only validated to tell us who may benefit from surgery to decompress the pudendal nerve. So what do I do in my practice? I believe that diagnosing pudendal nerve entrapment is like a jigsaw puzzle. You need to put all the pieces together and figure out if the patient has a nerve compressed. So I came up with my own criteria. I call it the Phoenix criteria. That criteria is not validated yet. It's not ready for publication. I can talk about it in this YouTube video, but like I said, it's not scientific, it's not validated. I hope with time it will. It is much, much simpler than Nantes criteria because it only has 4 points, four questions that you need to answer. Two of them are the same as a non-criteria, and two of them are different. Number one, did the patient have an injury that is consistent with pudendal nerve entrapment? I think it is unlikely to have a pudendal nerve entrapment if there is no injury that we know that can cause pudendal nerve entrapment. So for example, if someone just wakes up in the morning and has the pain in the area of the pudendal nerve, it is quite unlikely that the pudendal nerve is entrapped or scarred, because there is no trauma, there is no force around the nerve. However, if someone had a traumatic childbirth, if someone had a pelvic surgery that we know that may entrap the pudendal nerve, especially if that surgery was done with one of the pelvic meshes, which is around the pudendal nerve, or even the ones that is around the obturator internus muscle, then that is the surgery that may potentially injure the pudendal nerve. Number two, pain is consistent with pudendal nerve entrapment. So the patient has to have pain in the area of the pudendal nerve, and the pain has to be predominantly unilateral. I do believe that it's very unlikely to have an injury of the pudendal nerve on both sides. So to me, patients that have a real entrapment of the pudendal nerve have one-sided pain. There is an exception, and this exception are the bike riders, because the narrow bicycle seat, which presses against the sit bones here on both sides, where the Alcock's canal is. Yes, there may be a bilateral, which means both-sided injury to the pudendal nerves. But generally, most of the patients with a true injury to the pudendal nerve have one-sided pain. And generally, patients with pudendal nerve injury have more pain when they're sitting versus standing or laying down. However, a lot of patients will report pain when walking on the incline. A lot of patients will report pain when standing, so they're most comfortable when they're laying down. And also there are patients who have injury to the pudendal nerve from surgical material, whether it's a sacrospinous ligament suspension or pelvic mesh, and that pain will be constant. They have pain at night, they have pain during the day, and that doesn't necessarily change with the body position. And that is different than what is in the non-criteria. The third is the same as a non-criteria, and it's possibly the most important one, that the patient has to have a temporary relief of pain after pudendal nerve block. So when you block the pudendal nerve, the patient, number one, has to have numbness after this block. And then when the patient is numb in the area of the pudendal nerve, the pain has to be gone at least for as long as that numbness is present. So whether it's 30 minutes, 1 hour, 2 hours, the length of time doesn't necessarily matter, because different providers will use different local anesthetics. So if you use plain lidocaine, it may be an hour. If you use lidocaine with epinephrine, maybe 2 hours. If you use Marcaine with epinephrine, maybe 7 hours. So that does not really matter, but there has to be a disappearance of pain. Now, I hear from a lot of patients that said, well, I had a pudendal nerve block and my pain did not go away. So my next question is, were you actually numb when you had a pudendal nerve block? And the patient says, no, I was never numb. Well, if you were never numb when you had a pudendal nerve block, that means that that nerve block was not done properly. Because if you have a properly done pudendal nerve block, you should be numb. And if you were not numb, then whoever was doing your block missed. So that doesn't count. Like, that doesn't count. You had a nerve block that needs to be repeated. In my mind, actually, number 4 is also extremely important, and that's number 4, Phoenix criteria. You have to rule out all the other causes that can be causing this pudendal type pain, and by that I really mean the pelvic floor muscle spasm, because majority of patients that I see that present as possible pudendal neuralgia, what they really have is significant spasm of the pelvic floor muscles. And that's especially true if the pain is present on both sides. So like I mentioned before, we all have muscles at the bottom of the pelvis. And the spasm of this muscle is very painful by itself. And it's very difficult to distinguish between the nerve pain and the muscle pain. And in addition to that, the pudendal nerve, actually seen right here, runs through those muscles. It runs through the obturator internus muscles. So this is the Alcock's canal, and the pudendal nerve right here runs through the obturator internus muscle. So normally in patients without the muscle spasm, when the pudendal nerve runs through the Alcock's canal, there is a lot of room there. And when that obturator internus muscle is spasming, it is going to be spasming, or it is going to be tight against the pudendal nerve. So it's going to be compressing the pudendal nerve. Now, that's not a true pudendal nerve compression because there's no scar tissue, there's no surgical material. It is just the muscle that is spasming around the nerve. And in that case, the treatment for such a patient would be to work on the pelvic floor muscles and relax pelvic floor muscles in the ways that I have already discussed. So number 4 Phoenix criteria is to make sure that patient does not have pelvic floor muscle spasm, and if she or he has that muscle spasm, you have to work on the muscles and make them relaxed. And if the muscles are relaxed and the patient still has the pain in the area of the pudendal nerve, that most likely means that the pudendal nerve is compressed. So to answer the original question, I do not believe that MRI is the best way to diagnose the compressed pudendal nerve. I believe that you have to go through the elimination process to diagnose the entrapped pudendal nerve.